Alright, it is live now.
Yeah, it's live, Amol.
Yes, yes, it is live.
Perfect. Perfect.
Alright, it is live now.
Great, great, great. Thanks, Vinay. Thanks a lot.
Namaste. Good evening to participants from India, and good morning and good afternoon for those participating from overseas. So, I trust each one of you is safe and in the best of health. A warm and delightful evening to everyone present. I'm Pinakin Munshi, Vice President of the American Institute of Balance, India. As we celebrate 2 years since the establishment of AIB in India, I'm delighted to extend a cordial welcome to our esteemed speakers, insightful panelists, and engaged attendees for today's webinar, where we will be delving into the fascinating realm of vertigo and balance disorders. To kick off, some of you may not be, fully aware of AIB. So let me run through a quick, introduction about AIB. So just bear with me while I share my screen. Yeah. So American Institute of Balance is founded in 1992 by Dr. Richard Gans, and it is headquartered in Florida, USA. Dr. Gans is a PhD in auditory vestibular physiology and neuropsychology from the Ohio State University. He is a leader in the development of vestibular evaluation and rehabilitation techniques. He is also a research scientist and member of the American Academy of Otolaryngologists, Head and Neck Surgery, and the American Academy of Neurology. Coming to the India organization, Dr. Neha Shrivastava is the director of AIB in India. She is MS ENT and a practicing consultant neurootologist. She is a member, one of the youngest members of the esteemed Barani Society, and she is a member of the American Headache Society. She heads the RTKL Vertigo and ENT Clinic in Mumbai, and she's also the co-owner of RTKL Diagnostics Mumbai. So coming to the vision, AIB is committed to providing consistent and high quality evidence-based care in balance health to one and all, and providing professional development to practitioners throughout the world. So it's two things. One is the patient care, the other is the education part. So as far as the AIB mission goes, there are three aspects to it. The patient care, where we provide the highest caliber evidence-based treatment protocols. Education, where we offer various certification and courses which empowers medical professionals to treat vertigo and balance disorders. And research, there is an ongoing research carried out by Dr. Richard Gans and team, and they are adding to the research papers in diagnostic and treatment protocols. So as far as the benefits of the courses are concerned, when we come to training and certification, we in India offer this International Vestibular Rehabilitation Certificate course, which is an online course which can be taken by the people who subscribe to the course at your will, since it's an online course. It gives you access to all proprietary AIB clinical pathways and protocols. It has access to online video demonstrations, tutorials, etc. It gives you unlimited access to AIB articles and research papers, and it also gives the option of progressing to advanced certification. For the ENT surgeons, neurologists, neurootologists, they also have the option of going for a license whereby they can start a center of specialty care. And what it gives them is exclusive 36 months of license with a protected territory. They have the benefit of co-branding, which means they can use the AIB brand for the clinic, referral generating program, where patients are referred to them whenever they make an inquiry on the global portal. Clinical and technical support, both from India and abroad, discounts on technology and equipment, and on-site at AIB workshop of your choice for 2 days. The good news is, now AIB has decided to create a Vertigo support group. So this is being done under the aegis of RTKL. AIB has facilitated the formation of a support group comprising of patients who are affected by vertigo and vestibular disorders, and this group can be joined by the patients, the caregivers, and medical professionals with a view to share information, experiences, problems, and solutions. So the objective of the support group is to create a self-help group, a community which provides emotional support, shares common experiences, authentic information, and education to the members. The community will also help boost the morale and speed up the recovery of patients, by helping them cope up with the disorder and combating their conditions in a positive way. The platform is going to be WhatsApp, which means this community will be based on a WhatsApp platform, which, practically everyone has WhatsApp. So it makes it very easy to join this support group. The patient, caregivers, and the professionals can join by, scanning a QR code. So we have been promoting the QR code through various social media channels like Facebook, Instagram, LinkedIn. In case you have difficulty, you can also contact us if you find it difficult to get the QR code or joining the group. So AIB aims to contribute significantly to the quality and dignity of the patients through its vast repository of knowledge and its reliance on low cost or cost effective diagnostic techniques and low reliance on medicines or drugs. So these are the contact numbers. You will also find them on the webinar group. So we now actually move on to the presentations. So let's start with the first speaker. I'm honored to introduce our esteemed speaker, Dr. Nilotpal Dutta, a distinguished neurootologist. Dr. Dutta studied at Assam Medical College and completed fellowship in neurootology. He holds a DOHSN and MRCS ENT from the Royal College of Physicians and Surgeons of Glasgow and trained in pediatric vestibular at Alder Hospital. Currently, he heads the Vertigo and Balance Clinic at Medica Super Speciality Hospital. Welcome, Dr. Datta. The platform is yours.
Hi, hello, everyone. So, am I audible, Pinakin, sir?
Yes, you are audible, Doctor.
Okay. Thank you. First of all, I would like to thank the AIB India for inviting me for this wonderful academic webinar session. And especially like to thank Dr. Neha, who has been my friend and my colleague for a very long time right now. And I will also like to congratulate AIB India for who have been instrumental in spreading this awareness of vertigo and balance disorders in India, and also starting this vertigo support group, which is going to help 1,000 lot of patients who are actually unaware about these disorders, and also to create awareness amongst them so that they at least understand what the disease they are suffering from. And this vertigo is not a symptom, it has to be treated rather than sedating it with the vestibular sedatives. This idea has to be propagated to all the patients across the globe and across India. So the Vertigo support group, I think, would be a very good idea and will be instrumental in spreading this awareness and to create this awareness of neurootology, that this is a separate branch of ENT which deals with the practice of vertigo and balance disorders. So I'd like to congratulate again AIB India and best of luck for the upcoming programs and awareness campaigns which they run in the entire country. Now, wasting a lot of time, I'll just try to share my screen to the presentation. Pinaking sir, my screen is visible, sir.
Yes, yes, doctor.
So slides are moving.
Yes.
Okay. So without wasting much of time, so I would like to start on the topic which have been assigned for me today is one of the very common diseases which we come across in the field of neurootology is Meniere's disease. And everyone from this discipline, whether it's a postgraduate or a junior consultant, everyone or an undergraduate who is having the third year residency or third year of their MBBS level, they all know about Meniere's disease. So I'm not much going into the details of the history or pathogenesis. It's basically a disease where there is an endolymphatic excessive collection, which leads to vertigo, deafness, and oral fullness, and leads to vomiting, nausea. So these are basic things which everyone knows from the Meniere's disease. So my topic here is to discuss about the various latest therapeutic options available in the scientific literature today and what, according to me, is most suitable therapy and what in my clinical practice, in the several years of practice which I have been having till now, which drug or which intervention method have shown to be much more beneficial. I'll be discussing in the slide. Now, there have been a various treatment options available for the Meniere's disease. Now, it could be drugs, which drugs used in acute and prophylactic management. There are lifestyle modifications. And lastly, in some refractory cases, we'll be having the surgeries. Now, lifestyle modifications, if you see the role of salt restriction in Meniere's disease, now for time immemorial, now we also get a lot of prescriptions even today where we found that the doctor advises a salt restriction diet. So the patient is having a salt restriction diet for years now, but with vestibular sedatives, but there have been recurrent vertigo attacks. It is not stopping with the lifestyle or dietary modifications which are advised. Now, when I search through the literature, it shows that experimental data shows that low sodium diet results in nearly no change in plasma sodium levels. So there's no change. Even if you are taking low sodium intake, there has been no change in the plasma sodium levels. Now, endolymphatic levels of sodiums are essentially normal in histologically proven hydrops. When we do the histopathological examination of the ears having the hydropic ear disease, it was shown that the sodium levels were normal. Now, plasma osmolality rather than absolute sodium levels have led some researchers to shift focus from salt and sodium retention towards the transport and regulation of water itself. Hence, rather than giving much more importance to role of salt restriction, we need to enhance on the diuretics, which helps to drain the fluid rather than the salt restriction diet. Now, this is a Cochrane review, very latest article in 2018 published on the dietary changes in treatment of Meniere's disease or syndrome, which clearly states that there is no evidence from randomized controlled trials to support or refute the restriction of salt, caffeine, or alcohol intake in patients with Meniere's disease or Meniere's syndrome. So we are now quite evident that this lifestyle modifications of low salt diet does not actually have an effect in the control or prevention of the Meniere's disease. Now, coming on to the next modality, that is the drugs. Now, drugs we can phase out in the two groups. Now, first is the acute stage when you are having acute attacks of giddiness, where you'll be having very nauseatic, pukish, and vomiting with excessive sweating. So those acute attacks, like the other causes of vertigo, are usually aborted by vestibular sedatives or antiemetics. So what are the commonly used vestibular sedatives or antiemetics are fluchlorperazine, cinnarizine, dimenhydrinate, and benzodiazepines like clonazepam. Coming on to the prophylactic treatment, which has to be given after the acute therapy or acute vertigo symptoms have been aborted. Now, to cure, once you are diagnosed that the disease is Meniere's disease. Now, what are the prophylactic treatment available? In case of drugs, there will be diuretics, which I found much more beneficial, like acetazolamide, hydrochlorothiazide, furosemide, spironolactone. A few of the commonly used diuretics. We use beta-histine, cases. So all this I will be discussing in subsequent slides now. Now coming on to the symptomatic management. Now anti-vertigo drugs, what they cause they are central vestibular suppressants. Whatever you are using phenazine, dimenhydrinate, chlorpheniramine, or whatever. These are basically central vestibular suppressants which are used for the control of acute vertigo attacks in the case of Meniere's disease. Now chronic use to suppress the central adaptation or compensation to vestibular loss can thus perpetuate chronic imbalance. So what happens is these attacks, this symptomatic treatment of use of anti-vertigo drugs are best advocated. Now the latest studies have also shown, and there have been a lot of publications now with the big bodies of neuro-otology, including the Barony Society, which propagates that the use of this vestibular sedative should be limited to only use of maximum of 3 to 5 days during the acute attack. Because if we use these drugs with a long-term duration, then it causes a lack of sensitivity of the vestibular organs, so which lead to a permanent chronic imbalance. So your vertigo, a lot of patients now comes to us who says that the permanent vertigo is gone, but now they are having a case of imbalance. So there are basically 3 pharmacological classes of anti-vertigo drugs. The first generation antihistaminics are those which cross the blood-brain barrier and bind to several neurotransmitters. These commonly drugs used are dimenhydrinate, meclizine, and diphenhydramine. Benzodiazepines like lorazepam, diazepam, clonazepam are used. I preferably use a dose of 0.25 milligram clonazepam along with the anti-vertigo drugs to have a very good effect, especially under control of vomiting and sweating. Now, there are some other drugs like centrally acting anticholinergics like scopolamine, atropine, glycopyrrolate, which usually are not used in our day-to-day common practice, but literature has shown that they help to block the muscarinic receptors and thus prevent acute vertigo attacks. Now coming on to the prophylactic management. Once the diagnosis is done, now what drugs to be used so that actually the disease is cured? The most commonly used drug in the market, which everyone, starting from the GPs, gynecologists, ENTs, neurologists are using, are beta-histine. So what does the literature say? Did you ever get into the literature about why there has been a lot of use of beta-histine? What the scientific evidences have said? Here, I will be just giving a highlight of some of the points which are mentioned in the literature, which we need to be aware of before prescribing this drug. So this beta-histine is basically a histamine analog. It actually acts as a vasodilator directly on the neurons of the vestibular nuclear complex as a neuromodulator in histaminergic neural pathways. It acts on 4 types of histamine receptors like H1, H2, H3, and H4, and every receptor, it acts with a different function in all the receptors. Like in H1, the mode of action, according to Lecour, who is a very popular name in the field of neuro-otology, it shows that it increases its cochlear and vascular blood flow. The H2 receptor, it increases the histamine turnovers in the CNS. And H3 and H4 decrease in vestibular input in the peripheral labyrinth. So it works with the 3 different pathways. But there has been a lot of ambiguity on the use of beta-histine. Now, what are they? It is not an FDA-approved drug as there is no evidence of efficacy. Now, there have been a lot of variations in the doses of beta-histine, starting from 24 milligram per day to even 900 milligram has also been written in the literature. Now, high doses required for desired action of mode of action. A lot of studies advocate that low doses of beta-histine, which we commonly prescribe in our day-to-day routine practice, actually doesn't have any effect in the vestibular system or in the prevention or control of Meniere's disease. Now, may lack efficacy if we are using with phenazine. So not better than a placebo, even at 3 times the approved doses. These studies, I'll be showing the glimpse of it. Like latest BMAT trial and Cochrane review has shown that it did not show, because of beta-histine did not show much beneficial effects with beta-histine in Meniere's disease. So all these are not my words, which I'm saying. All the references are quoted below. You can search it. If anyone further wants the evidence, you can contact me. I will can send you all these references. Now, this is the clinical practice guidelines according to the American Academy of Otolaryngology and Head and Neck Surgery, which clearly states if you show that the reported side effects with beta histine, the common ones are headache, balance disorders, nausea, nasopharyngitis, irritation, palpitation. Now, you have to be very much clear, otherwise you may be sued in the court. To always think it, now patient is coming to you with a balance disorder and acute vertigo. Now, we are prescribing a drug which has a side effect of balance disorders and headaches and palpitations. So we have to be aware and have to be sure about the disease and then to prescribe and what dose to be prescribed depending upon the patient comorbidities or patient weight or patient symptoms. Now coming on to what does the other literature say? This is a very popular article which you can come across. Is a BMed trial where some of the big names in neurotology, again like Robert Guthhoff and Michael Stroop, which everyone now is aware of. It says that the long-term prophylactic treatment with beta-histine dihydrochloride does not change the time course of vertigo episodes related to Meniere's disease compared with placebo. Now, placebo intervention as well as beta-histine treatment showed the same reduction of attack rates over the study's 9-time period. Means there has not been a much of difference of prescribing beta-histine and placebo according to them. This is another Cochrane review which shows that there is an insufficient evidence to say whether beta-histine has any effect on Meniere's disease. So, what is the conclusion now? According to American Academy Clinical Practice Guidelines, it shows that there has been, therefore, the authors have noted that better quality evidence is needed to evaluate the effectiveness of beta-histine as compared to placebo, and further studies are required. Now, this is an article which was published by me and my guru and mentor, Dr. Anirban Biswasar, a few years back, which have all these publications like role of beta-histine in the management of Meniere's disease. This is a freely downloadable article. Anyone who is interested to know about more about beta-histine and its myths or how it actually works for the vestibular system can go through this paper. Now, if not beta-histine, what should be the drug of choice? Now, as we know, the most commonly propagated pathophysiology of Meniere's disease is hydrops. Now, what is hydrops? The medical definition of hydrops is edema or a distension of an hollow organ with a fluid, according to the Merriam-Webster Medical Dictionary. Now, any distension of hollow organs with fluid or any edema anywhere in the body is medically treated with diuretics. Now, if you are having an edema of your leg or a pulmonary edema, what do? We basically use a diuretic. If you are having a blood clot due to a hemorrhage, what do we use? We use Lasix, we use Rexona. Our main thing is to reduce the volume of that. So why not hydrops in the inner ear? It is very much practicable and scientific to use a drug which actually reduces the amount of fluid. So why we use diuretics? Very good personal clinical experience with Meniere's disease, the justification and scientific logic behind use of diuretics in hydrops as compared to beta-histine, which I have found in the science literature. Now, relevance of carbonic anhydrase inhibitor effects of diuretics like acetazolamide that also help in decreasing the secretion of endolymph. Now, diuretics, if you use acetazolamide, it actually acts on the stria vascularis, which is the pathogenic center for excessive secretion of the endolymph. So, it actually blocks that center, and after the fluids are taken out with the use of other diuretics, if you use acetazolamide, it actually prevents to secrete the further amount of fluid. So ultimately, it's a very good control for that. The most propagated mechanism of action of beta-histine that it decreases the formation of endolymph by enhancing the blood flow in the stria vascularis, which have been propagated by a lot of the drug companies now into the market, is just an hypothesis and not yet proven that there is hypovascularity in the cochlea, and that actually leads to hydrops. It's basically a myth or it's not been proven yet. Now, this is a very pilot study which I have done. It's not a RCT trial or not I have published it, but this were used like an inclusion criteria in the unilateral Meniere's disease, like a very typical history. We have included some patients who have typical history of vertigo with deafness or oral symptoms which are time locked with the vertigo episodes, and mild to moderate severe degree of ascent deafness of cochlear origin. We included both the glycerol and ECOG tests, which are routinely done in our center, and we have included those patients which were non contraindicated for diuretic symptoms, like your CKD patients or other patients where diuretics cannot be used much, and complete vestibular function tests like VNG, VHIT, VEMS, SBVDV, all these were used, and no history of any ear surgery or other reasons of vertigo and deafness were ruled out, and actual presenting with symptoms of Meniere's disease were included. These are some of the graphs we use, like the glycerol. First one is that glycerol test, where we have found an improvement in the level of glycerol after glycerol dehydration test, and this is the electrocochleography. So total number of patients in our study was around 120. So age group was 22 to 71 years, and what we did for follow-up was we usually revisited the patients. Of around 85 patients were followed up with revisits, and 15 patients by telephonic follow-ups. And what are the drugs we use are basically acetazolamide, hydrochlorothiazide, and spironolactone, or a combination of these drugs. And medications are usually continued for 3 months. But what I do is I prescribe it for 1.5 months. Ask the patient how many attacks have been there, how is he able to adapt to the drug, or is there any severe side effects. If it's there, I stop or do some other change the drug. And if there is recurrence after stoppage of medications after 3 months also, then another 6 weeks of additional diuretics are given, and follow-up is done with telephonically or physical visits according to patient profile, which follow-ups are done at the age of at the time of 3 weeks, 3 months, and after 6 months also. And out of this, whatever studies I have done is 98 patients showed full symptom remission from both vertigo, usually, and in some patients there have been improvement in the hearing also. However, in 11 patients, diuretics were discontinued due to severe electrolyte imbalance and incompatibility of the patients with the drug. And in 10 to 11 patients where we could not use the diuretics, abortive therapy or like beta-histine or acute vestibular sedatives and intratympanic gentamicin were advised. Now, these are some of the old studies which I'm not going through much. These are given in the literature where they have shown to be improvement in Meniere's disease. These are mechanism of action of diuretics, like osmotic diuretics like glycerol or furosemide cause rapid dehydration followed by decrease of inner ear pressure. And diuretics not only cause dehydration but also possibly also have effects on labyrinthine electrolyte regulation, which actually helps to prevent the Meniere's disease. And is diuretics increases excretion of sodium but decreases excretion of potassium, which is another mechanism of action which I've shown. Now, these have been role of acetazolamide, which is the most common diuretic which has been prescribed in the market today. And it shows that some of the published reports of symptomatic improvements in patients with Meniere's disease following acetazolamide administration, like carbonic anhydrase inhibitors, and increase of osmolality in perilymph, but not serum osmolality. So these are basic mode of action, how it works, and it actually helps to decrease the secretion of endolymph. Now, this is a very interesting study which have been given by 2016 and 2020 article by Sheffardi and Gurkov, which shows the direct evidence of decrease of hydrops by MRI gadolinium studies. It showed that Sheffardi et al. In 2016 showed that reversal of hydrops following diuretic treatment confirmed by intratympanic gadolinium MRI. This is an important advance considering the literature that suggests that diuretic treatment is ineffective in Meniere's disease. Now, another article by Gurkov, it shows that beta-histine medication had no effect on hydrops measured by MRI. So this would best fit with idea that beta-histine does not affect hydrops much. Coming on to the next set of drugs is the role of migraine prophylactics in the management of Meniere's disease. Now, Prosper Meniere, who is the father of invention of Meniere's disease, we call, himself have observed the association between Meniere's disease and migraine from its inception from around 1862. Now, studies report higher prevalences of migraine in patients with Meniere's disease, ranging from around 43 to 56%. Now, interestingly, the reverse is also true. Like prevalence of Meniere's disease among migraine patients, if you can ask for a history, if you take a thorough history, then you'll get a lot of these correlations. And this is not written in the literature only. I have personally also experienced this. If you ask for the history, you'll get a lot of patients. Around 70 to 80% patients with Meniere's disease would have a history or one or two features of migraine or here and there. So overlapping symptoms and epidemic association could indicate an underlying pathogenic link between Meniere's disease and migraine. So this is according to Acta Otolaryngology published in 2010, which showed that migraine-associated vertigo and Meniere's disease, their symptoms are mostly vertigo, sensorineural deafness, and tinnitus in both the ears. Now, some published literature on Meniere's disease and vestibular migraine. Now, migraineurs have higher prevalence of vestibular symptoms than again of the general population. More patients of Meniere's disease have migraine than general population. Now, studies have shown between 43% to 56% prevalence of migraine in Meniere's disease, whereas in normal populations, the prevalence of migraine is less. And higher prevalence of Meniere's disease in population screened for migraine than general population. So all these are published literature. All the references are given, which strongly advocates that there is a very strong link between Meniere's disease and a vestibular migraine. So what are the drugs which are found to be useful in the management of Meniere's disease or a Meniere's migraine complex disorder? Like beta blockers like propranolol, calcium channel blockers like flunarizine, anticonvulsants like topiramide, which works very well, and valproic acid or the divalproic sodium, and antidepressants like amitriptyline and venlafaxine. These are some of the drugs which are routinely used and can be used with very good effect in patients with a Meniere's migraine complex disorder. Now, coming on to the next state of treatment, our positive pressure therapy called the Meniere device. This is not routinely practiced nowadays, but this basically I'm just going through some of the pathophysiology, how it works actually. The function is transfer of pulsatile small pressure from external to inner ear, result in displacement of excessive endolymph, appears to be more of theoretical than usually practical, and various RCTs in literature have also mentioned there is no significant difference in impact of vertigo control with the use of positive pressure therapy, and did not, several RCTs and randomized control trials and Cochrane reviews did not recommend much the use of positive pressure therapy like Meniere's disease. Coming on to another very commonly used drug in the refractory cases of Meniere's disease, which are refractory to use of drugs, is intratympanic gentamicin, which have been used for time immemorial now. The aminoglycoside that causes toxicity to the inner ear, especially targeting the sensory cells of vestibular system and hair cells of the cochlea. Now, gentamicin has a strong pedilatation towards chemically ablating the vestibular system, hence permanently stopping the vertigo episode. It has been shown to decrease the vertigo symptoms in Meniere's disease and is less invasive than the other surgical ablative procedures. Now, same and effective treatment options for patients with unilateral Meniere's disease who have failed more conservative treatments. In these cases, intratympanic gentamicin can be used, but should be avoided in bilateral Meniere's disease patients due to risk of bilateral vestibulopathy. Now, coming on to intratympanic steroids, it has been a lot of controversies now that whether to use intratympanic gentamicin or steroids. What the literature says is role of intratympanic steroid therapy in Meniere's disease first described in 1991, and it stabilizes the vascular endothelium and improves the cochlear blood flow through anti-inflammatory effects as well as effects on cochlear ion and fluid hemostasis. The dose, basically, if we are using dexamethasone, we use it 4 milligram per milliliter, and methylprednisolone is 30 mg per ml. So usually injection is 0.4 to 0.8 ml into the middle ear space from once only to at least 3-4 sessions every 3 to 7 days, depending upon how many attacks the patient is having and how severity are the attacks. Now, intratympanic steroid and the intratympanic gentamicin, the level of evidence, what the literature, there are a lot of publications there, you'll also get it. Level of evidence in control of vertigo with intratympanic steroid therapy is less as compared to intratympanic gentamicin. Intratympanic gentamicin therapy provides superior control in patients with severe or recurrent Meniere's disease. Only very few studies have shown similar control systems with Meniere's disease with both IT tympanic steroids and intratympanic gentamicin. So more studies of intratympanic steroid is required according to the literature. Now, lastly, the surgical options in the treatment of Meniere's disease. The decline in use of surgical options of Meniere's disease in most recent publication is due to rise of less invasive treatment procedures and advancements in the drug therapy. And also, we now know about more into the pathophysiology of Meniere's disease, and hence the appropriate drug therapy, if we use in more than 90 to 95% patients, we get effective results either by drugs or in gentamicin. In less than 5% patients, we use surgeries. So this will be discussed in the later session by Jayashankar sir, where he will be discussing on surgery on vertigo. So I'm not going into the details of it. Just the surgeries which are used in Meniere's disease are labyrinthectomy, vestibular nerve dissection, or endolymphatic sac decompression, which was used very commonly in the past. Now, comorbidities with these surgical procedures is complete vestibular hypofunction and hearing loss, possible tinnitus in affected ear with prolonged chances of postural instability. So lastly, to wind it up, we conclude that diuretics do have a positive role in therapy of Meniere's disease that is evidence-based, ethical, and scientifically logical. Now, salt restriction does not have a much proven role in the Meniere's disease, as from the lot of literature which I have shown. Beta histine possibly also has a positive role in Meniere's disease, as evidenced by some studies, but the mechanism of action is not much clear, and possibly the doses of beta histine which we are using in our day-to-day practice have to be rethink, and we have to give it at a much higher dose. And intratympanic gentamicin rather than intratympanic dexamethasone have shown significant improvements in control of Meniere's disease. And as Meniere's disease and vestibular migraine share a common origin, as evident from literature, migraine prophylactics are very effectively used with adjunct treatment in Meniere's disease. However, more research needs to be done on the use of diuretics and acetazolamide, furosemide, hydrochlorothiazide, or spiramide, and a reacceptance of diuretics in the treatment of Meniere's disease is actually needed. Thank you everyone for our patient hearing, and also like to thank AIB India for this opportunity to present here today. So with that, I would like to conclude this session. Thank you.
Thank you, Dr. Dutta, for an excellent lecture. And thank you for joining us today. It's an absolute delight to have you amongst us. Thank you. So our next speaker is Dr. Narayan Jayashankar, an esteemed ENT and skull-based surgeon. Dr. Jayashankar practices at Nanavati Super Speciality Hospital and PD Hinduja Hospital in Mumbai. Renowned for his work in neurootology and skull-based surgery, he has been invited as faculty to over 250 workshops worldwide. He has published numerous papers, reviews, journals, contributed to textbooks, and authored 2 atlases published by theme. Welcome, Dr. Jayashankar. The platform is yours.
Thank you very much. First of all, I'd like to say a thank you to AIB India for inviting me and allowing me to give a lecture on surgery for vertigo, very close to my heart. And without much ado, I'll just start screen sharing.
It's our pleasure, Doctor.
So thank you to Dr. Neha Shrivastava again and the whole team. So today I'm going to speak to you. Do you have my slideshow with you?
Yes, it's clear. It's visible.
Okay. So as mentioned, I'm an ENT and skull-based surgeon. I do all types of skull-based surgery. And of course, vertigo surgeries fall into the realm of neurotology and skull-based surgery, which I am, and that's how I happen to be here. So again, coming back, we had a fantastic lecture already by Dr. Dutta, who explained all about the Meniere's treatment. Okay, and Meniere's, as you all know, is primarily a treatment, medical treatment. So surgeries are only for the intractable cases of vertigo of Meniere's. Okay, 95% or so of the patients of Meniere's are treated medically. It's only these intractable vertigo patients, and they are not very often, as I already told you, it's about 95% are treated medically. It's about 5% of cases worldwide that are treated surgically. And it's these cases of intractable vertigo which we offer the following surgeries. First is an endolymphatic sac decompression. I'll talk to you about it. Transmastoid labyrinthectomy, and more popularly is the retrosigmoid selective vestibular nerve section, which can also be done by a middle cranial fossa approach. So coming back to endolymphatic sac decompression, we will discuss each of these topics and we have to select our cases, whether it's endolymphatic sac decompression, a labyrinthectomy, or a vestibular nerve section. We have to select these cases, and that's what I'll throw light on. Which cases, or I'll give you case examples of how you decide what surgery should be done for these patients. Of course, other causes of vertigo are superior semicircular canal dehiscence. I'm not going to be laying emphasis on that. Very, very rare case. We do it by either a middle cranial fossa or a transmastoid approach. Find the fistula on top of the semicircular canal and put some amount of soft tissue and bone dust on top of it and seal it up. And again, surgery for vestibular neuroma, which is again a cause of vertigo and imbalance. We generally, there are 3 procedures used. We use most commonly translabyrinthine approach for vestibular schwannoma. If the hearing is gone, if the hearing is serviceable, then you would probably go for a retrosigmoid approach, and if it's an intracanalicula with preserved hearing, you would go for a middle cranial fossa approach for the vestibular schwannoma. So again, coming back to case backgrounds, I'll give you clinical cases, and then you will be more in a position to figure out how we go about selecting these cases. Now, 40-year-old male patient, symptoms were related to the right ear. There were episodes of mania since 6 months, disturbing the quality of life, severely disturbing the quality of life, I would say. Medical treatment tried, various doctors tried by even me for a significant period of time, but not really very effective in curing his episodes of vertigo. Audiogram, of course, shows just a 35 dB low frequency mixed hearing loss in the right ear. So in these cases where your hearing is preserved, you cannot offer destructive treatments. Hence, this was one of the cases where he didn't want to do too much. You have to give them options, and that's where we gave him the option of endolymphatic sac and mastoid shunt. So when endolymphatic sac surgery started, people had described as just a decompression of the endolymphatic sac. We know that the endolymphatic hydrops is the cause of the problem, but just a decompression of the sac is what was initially proposed. Then people further refined the procedure and made it into an endolymphatic mastoid shunt, which is most commonly done. There were also cases where they had endolymphatic sac subarachnoid shunts, which were inserted. But most commonly performed is endolymphatic mastoid shunt, where we incise the endolymphatic sac and create a sort of a opening in the sac, and that helps to prevent these attacks of hydrops which the patients complain of. Coming back to the surgical nuances of this case, you see this is the right side ear, that's a temporal bone. You see a cortical mastectomy has been performed for all the ENT surgeons in the group. Here you see that's the region of the antrum. This is the dome of the lateral semicircular canal here. This is the dome of the posterior semicircular canal, and this is the superior semicircular canal over here. That's the middle fossa plate. This is the sigmoid sinus. And of course, that's the vertical course of the facial nerve, or the mastoidal segment of the facial nerve, as you all know about it. So where does this endolymphatic sac lie? It lies along this line, inferior to this line. So Donaldson described this line that goes along the long axis of the lateral semicircular canal and bisects the posterior semicircular canal as it goes towards the sigmoid or retrosigmoid dura. Okay, pre-sigmoid dura, I'm sorry. Okay, and it lies inferior. So it will generally lie in this area inferior to this line. Now, how do you follow this in live surgery? You have to identify the sigmoid sinus. The pre-sigmoid posterior fossa dura has to be identified and decompressed. So you typically go about drilling with a diamond burr as you come closer and closer to the dura and lift up the last shells of bone over this area. You do not need to blue line the posterior semicircular canal as many people had described it. It's enough to follow this pre-sigmoid dura and go as close to the posterior semicircular canal as possible. And then you will see this. This is of course a dissection specimen of the whole thing. Pre-sigmoid dura, that's where the elevator is kept here. That's the endolymphatic sac over here. How do you identify this endolymphatic sac? Is the dura and the endolymphatic sac are different colors. The endolymphatic sac is actually a double fold of dura, and you can feel your instrument abutting it, and you feel it like a small ledge on this dura. It's not a very smooth dura over here. Again, that's not really confirmatory, because if you incise it, you may even go intracranial. The correct way to do is press this endolymphatic sac down, and you'll see the endolymphatic duct that goes deeper to the posterior semicircular canal. And that's the most confirmatory evidence that this is in fact the endolymphatic sac. So you have to decompress pre-sigmoid dura on either side of this, identify the color change, identify the endolymphatic duct, and then it's a thickened dura over here, which you need to open up for surgery. So again, here in live surgical specimen showing you the same thing, I've purposely sort of marked all of this. That's the fallopian canal, vertical segment, posterior semicircular canal, which is here. You can see the endolymphatic sac as a double fold of dura, a posterior fossa dura on both sides. And if you press this endolymphatic sac downwards or medially, you would see this endolymphatic duct that's going deeper to the posterior semicircular canal. Again, make a simple incision on this endolymphatic sac dura. You can see my ballpoint probe having gone into the lumen of the sac, and you can see that the lumen of the sac is quite open. You should be able to put this ballpoint probe without actually going through the medial part of the sac. If you do that, then you're likely to get CSF leak, and then you're going to be more in trouble. So identify the sac accurately, incise the sac, go into the sac, make sure it's clear, and then go about putting a small piece of silastic. Here, what we do is we put a T-shaped silastic. If you just leave it alone, the endolymphatic sac will readhere and reclose. So we put a silastic sheath which maintains the patency of this opening of the endolymphatic sac, and then the endolymph keeps on draining out whenever there's an excessive endolymph production, and that presumably stops the attacks of vertigo. However, okay, this is again the same picture of the endolymphatic sac with the silastic in place. However, we have also found that the success rate is only about 75%. Although it appears the most logical way to prevent an endolymphatic hydrops, the success rate is just about 75%. And the reason for this is not known. We really do not know. We need to dwell more into the causes of this and why the success rate is only 75%. So I personally have done very few cases of endolymphatic sac decompression, just less than 10, I would say. And although I've had good success rate, I have seen patients coming back operated by other surgeons all over the country, and have seen them coming back with recurrent attacks of vertigo. So it's not, my series is very small to relay any and say that yes, this is a good series. It's not really true. I've seen a lot of patients who have got a surgery done by very, very good surgeons, in fact, and have still come back and complained of symptoms related to males. So again, results have to be, patient has to be explained that the results are as good as 75%. And of course, medical line of therapy also gives 70 to 75% results. So you have to offer this to the patient with a certain amount of wariness, and you have to give them, really counsel them well that yes, we would, some patients do very well with this surgery, but there will also be a group of patients who will come back with episodes of veneers, and then you have to treat them medically. A second clinical case that I would like to present to you is a 46-year-old female, symptoms related to the left ear. Okay, episodes of mania since 4 years, but more frequent since 8 months and disturbing the quality of life severely. All these patients are typically patients who have vertigo every 2-3 days, not able to work, typically hold their head and sit. And the vertigo lasts for a few hours in the day and associated with severe vomiting, headaches, and severely affecting the quality of life. So not able to go to work. So medical treatment again tried, but not effect. An audiogram, of course, showed a 75 decibel hearing loss because it was a long-term meniere's. The patient had already got a 75 decibels mixed hearing loss in the left ear. And that's the reason I decided, let me attempt to do, in this case, a transmastoid labyrinthectomy. Now, again, a labyrinthectomy is only done when you have unserviceable hearing. The patient has, really got no significant or serviceable hearing, and the patient should be counseled about this because it essentially means that the patient is going to lose any remnant hearing in that ear. So do it again with a word of caution to the patient, weighing your pros and cons, and in consultation with the patient. Okay. So that's again the the left ear of the patient here. You can see for the people, ENT people in the audience, that's the tegmen, that's the sigmoid sinus. This again is the dome of the lateral semicircular canal. This is the region of the mastoidal segment of facial nerve, which is retained very well within the bone. And you can see just about the posterior semicircular canal. The superior semicircular canal is not completely evident in this. So what we do is retaining this facial nerve intact along its vertical course, because this facial nerve is the most critical structure you have to preserve in these labyrinthectomy cases. You must not overdrill on the lateral canal because this lies just anteromedial or just medial to the belly of the dome of the lateral semicircular canal. So here you're seeing a slit made. This is just for demonstration purposes. I made a slit in the lateral semicircular canal. You can just about see the slit in the posterior semicircular canal. And here is the superior semicircular canal. Again, you can make out a superior canal slit being made over there. Now, what's the end point of a labyrinthectomy is you really have to destroy all the end organs of this labyrinth. So essentially, you have to drill out the whole labyrinthine block. You have to destroy all, sorry, you have to go back and destroy the superior semicircular canal, the ampullary, as well as the non-ampullary ends. Same with the other two canals, and go and see the vestibule. So as you go deeper and deeper, just deeper to the second genu of the facial nerve, you have the vestibule over here. And what you're supposed to do is open up the vestibule and take off the neuroepithelium. So essentially, you're destroying the ends of the ampullary, non-ampullary ends of the of all these sensory organs, as well as to remove the neuroepithelium of the vestibule. Take care not to put your instrument too deep in, or you'll dislocate the stapes, and the other side and cause further problems. So just go about it, remove the neuroepithelium, make sure that this whole bone is intact. I mean, is drilled completely. Make sure you're not leaving behind any end organs of the vestibule, and you would be, doing a complete labyrinthectomy. Again, a success rate approximately just over 85%, as is described in various series in the literature. And this is also one of the options for the patients. Now, both these options do not really give 100% or very high percent of improvement. Patients of labyrinthectomy could still complain of tinnitus. And of course, there is always a risk of hearing loss. And if it's a younger patient, you really don't want to give them this issue of hearing loss in these patients. So I always very selectively do not try to give these patients a transmastoid labyrinthectomy, although it's given good results above 85%. We have to reserve these cases for ones which have really severe to profound hearing loss patients. So that is why the most preferred technique today is the retrosigmoid selective vestibular nerve section for intractable Meniere's. Now, this was described by various people in say in the later of 1900s, and they started doing a middle cranial fossa vestibular neurectomy. They found this to give rise to some amount of hearing loss, and it had its own problems. And as you all know, a middle cranial fossa is not as easy to perform. It requires a lot of experience to be performed, and hence people shifted back to retrosigmoid vestibular nerve section. The retrosigmoid vestibular nerve section offers a wider area, and it is very selective in that we are not destroying the hearing. So the cochlear nerve is preserved and only the vestibular nerve is cut, and this has the highest success rate, and this can be offered to patients with preserved hearing to cause a great amount of success. Now, this is a small video over here. It has got a volume, but I think what I will do is I will cut down the volume over here, and I'll give you an online lecture for the same thing. So again, although I do these cases, I always keep my neurosurgeon, Dr. Rajesh is a neurosurgeon I work with at Narayan Hospital. Whenever you cross the dural barrier, you have to have a neurosurgeon in your team. So again, vertigo, almost 2 to 3 days, severely disturbing work and quality of the life since more than a year, fullness of the left ear, all classical symptoms of Meniere's, medical treatment received but no significant relief, audiogram showing a 40 dB mixed hearing loss in the left ear. And again, for these patients, you need to do an MRI of the brain with contrast, which again said it is normal. So these patients then with severe amount of vertigo, making sure that they have Meniere's disease, you have a proven diagnosis with an MRI normal and just a 40 dB hearing loss for a young boy. I think I offered this patient a retrosigmoid. So retrosigmoid, again, you need to know the level of the transverse sinus superiorly, the sigmoid sinus over here. And what we do in these cases is we create two flaps. Okay, the incision is made over here, sort of in a posterior way, C-shaped manner here, starting from this transverse sinus and going down here towards the mastoid tip, way beyond the retrosigmoid, beyond the sigmoid sinus. On the other hand, the musculoperiosteal flap that I elevate would be more posteriorly based. So skin incision anteriorly based and musculoperiosteal posteriorly based. Now, why do we do this? Is because we really want to prevent CSFB occurrences. So once we suture the muscles anteriorly, you can see this muscle getting reflected posteriorly. So that's why it is posteriorly based. Now, when you take these muscle anteriorly based and skin posteriorly based, you're decreasing the incidence of CSFB because the incision sites do not really overlap each other. There is the mastoid emissary vein in the retrosigmoid area there. Whenever you see that, you identify it and use bone wax. Okay, nothing to really worry about the emissary vein. It's going to be, and your whole craniotomy is going to be based on the emissary vein right at the center. So you really have to go take this muscle posteriorly, not really do a retrosigmoid craniotomy as big as neurosurgeons do it for tumors. For tumors, a very large retrosigmoid craniotomy is done. But here what we do is a mini craniotomy. So you can see over here, not a very big craniotomy, just about 4 into 3 centimeters. Whereas for tumors, we do, the neurosurgeons, of course, do a very large retrosigmoid craniotomy going way down towards the foramen magnum. You can see here, my burr is, I've drilled with a cutting burr initially. I'm using a diamond burr over here. You can just about see the bluish tinge of the sigmoid sinus over here. Superior limit would obviously be your transverse sinus. Your center of this craniotomy is going to be a mastoid emissary vein, and you're going about 3 to 4 centimeters posteriorly and coming down here towards the occipital. Drill with a diamond burr as you go closer and closer to the dura, because as you go closer and closer to the dura, you don't want your cutting burr really causing a rent in the dura. So here you see the bone chip being lifted off completely. Over here, again, you can see a thick block of bone, and this block of bone will be placed back at the end of the procedure. So you can see the posterior fossa dura, that's actually the retrosigmoid dura. Sigmoid sinus is in the front, transverse sinus is here superiorly, as you can see it. And just any small vessels or bleeders like this, you can use a little bit of bone wax and seal it. It doesn't really cause any issue. The idea is you must have a good hemostasis in all these cases before you really open. I do not like, or you should actually not really have any blood as you open the CP angle area. You must try to work in as clean a field as possible. So there you see the retrosigmoid dura has been exposed. Now we're making a craniotomy. We're opening the dura. I open the dura like a flap and sort of go very gently with it. Now, when you incise this dura with a plate, you must make sure they do not going to accidentally damage the veins over the cerebellum. So go very gently, use your blade, lifting up the dura from the cerebellum, liberal amount of irrigation. And once you do that, you could insert a small piece of patty over there in the incised area so that the patty really protects your knife from hitting on the cerebellar vein. So you can see that a small patty over there, and then you can see that the vein, the dura is actually being lifted off, and you can actually see the cerebellum below it. So once we do this dura is shifted and reflected anteriorly. And once you do that, you're obviously seeing the cerebellum. Now, seeing the cerebellum is not enough. You really need to see the CP angle area. And that's why you need to drain a little bit of CSF. You see over here, cerebellum in your view. I have no view yet now of the CP angle, but there you go with a patty, protect the cerebellum, protect the veins of the surface of the cerebellum. All this is done by me, of course. We protect the cerebellum and gradually depress the cerebellum gently, medially, that is inferiorly and posteriorly. Okay, once you do that, you're opening up the CP angle system. Now here, I'm taking a small, very small needle-like hook and trying to open up the arachnoid. Once you open up the arachnoid, a lot of CSF drains off, and that further helps in settling the cerebellum down. Else your cerebellum is going to be in your way. So here you're seeing the petrous ridge, and you're seeing here me opening up the arachnoid of the CP angle area. And once you do that, the 7th, 8th nerve complex comes straight into your view. Not enough just to see it, you must be able to get access to the 7th, 8th nerve complex on both sides. So that is why it's important to open up the arachnoid. There you can see the 7th, 8th nerve complex beautifully. The 7th nerve is placed a little bit anteriorly. Anteriorly is away from us. So there you see my instrument now pointing to the 7th nerve, which is placed more anteriorly, that is away from us. And the ones closer to us here is the vestibulocochlear complex. Now here you can see the blood vessel that is running on the vestibular nerve. The vestibular nerve is more superior, and the vestibulocochlear nerve is one complex. You can see me dividing it. There's a cleavage plane in between the vestibular and cochlear nerve, which you have to identify. Again, the vestibular nerve is a little bit more grayish compared to the cochlear nerve. So here, what you need to do is you're preserving the cochlear nerve, you're preserving the facial nerve, and only sort of isolating the vestibular nerve. You can see a small vessel. Do not touch these vessels. These will be labyrinthine. These vessels supply the labyrinth and sometimes even the facial nerve. So you really do not want to damage that vessel. So once you're able to create a cleavage plane, I'm taking one scissors and taking a sharp cut on the vestibular nerve. You see that it's not too far from the brainstem. It's just a sharp cut, single sharp cut on the vestibular nerve, and that's your vestibular nerve cut. As soon as you do that, the vestibular nerves go a little away from each other. Make sure that all the vestibular fibers are cut. Here you're being very careful because you have the cochlear nerve. You really don't want to cut the cochlear nerve. Neither do you want your scissors injuring the facial nerve, which lies much more deeper. That's more anterior to it. You can see behind the vessel, the facial nerve is preserved intact. You can see to the left of the cut nerve is the cochlear nerve, and you can see the vestibular nerve, which is being separated. So take off any other remnant fibers of the vestibular nerve, shift these vestibular end cut fibers away from each other. If you keep them too close to each other, they could possibly reoppose. So you try to push it away from each other, and then you can see the vessel preserved, the facial nerve way down there in depth, and the cochlear nerve preserved. So this patient, we were able to preserve the hearing as much as the pre-op levels. And again, this patient got fantastic relief of vertigo. I won't talk about how we close this. Again, if you want to see this patient has got a normal face. This is the immediate next day after operation. Facial nerve completely preserved, and hence you can see the bandage on the ear. Patient is in the hospital and face is completely normal. And this is the patient who had slight imbalance for a couple of days, but then he walks into my clinic 7 days later, and this is in my clinic. You can see him walking effectively. He was a gym instructor, and he earlier had given up his job, and now he says, I could, in 1 week's time, he's feeling so confident, he's walking forward, backward, and he had no problem. So he's just giving a small speech over there saying how good effect he's got. It's been over a year since I've done this surgery, and this patient still hasn't come back with any episodes of vertigo. And this is not one of the cases. These are some of the cases that I've done for vestibular neurectomy. So success rates are more than 93%. Okay, very few patients come back. If the surgery is not effectively done, if your diagnosis is not correct, then you could probably have. But otherwise, success rate in most series is extremely high. Very good chances of recovery, and that is why today it is one of the most preferred routes. We do not offer endolymphatic sac decompression. We do not offer transmastoid labyrinthectomy. If a patient needs to be operated for, say, intractable vertigo, I will give this patient a vestibular neurectomy. Offer this patient a retrosigmoid vestibular neurectomy. Okay, so that is all treatment for many years, surgical treatment. I'm not drilling, I'm talking much about the superior semicircular canal. Again, vestibular schwannoma, you all know, causes imbalance. Again, I will not talk to you how we select these cases. The translabyrinthine approach is done for patients whose hearing is gone. You can see the right ear of this patient, almost unserviceable hearing gone down to about 75 to 80 decibels. And you can see a vestibular schwannoma on the right side of this patient. So quickly, for the ENT surgeons in the group, again, you can see the mastoid over here. You can see the sigmoid sinus. Again, what I already showed you, the vertical course of the patient are preserved. That's the lateral semicircular canal, posterior semicircular canal, and superior semicircular canal over there. You can see me having drilled the canals, go towards the vestibule, just as I already showed you in the transmastoid labyrinthectomy. Go further on, decompress the pre-sigmoid dura. This is all sigmoid sinus, pre-sigmoid posterior fossa dura. And for the people, again, just to show you a glimpse of the endolymphatic duct, which travels deep to the posterior semicircular canal on its way to the vestibule over there. That's a glimpse of that duct over there. So we really need to cut off this duct over here, finish your labyrinthectomy, and then go about and identify. Now, here is the labyrinthectomy which has been complete, and you can see the vestibule. The internal acoustic meatus lies deeper to the vestibule. So the white block of bone that you can see deeper to or medial to the vestibule is the internal acoustic meatus. That's one line. That's the superior aspect of the internal acoustic meatus, superior lip where I expect it to be. And you have to drill in an area between the superior lip and the tegmen, which lies superior. So the idea of doing this again is to go around the internal acoustic meatus. Again, this line denotes the inferior lip. So you're drilling in the area between the inferior lip and the jugular bulb, which lies inferiorly. So when you do this, you're not having just a 180-degree exposure of the internal acoustic meatus. You're having almost a 270-degree exposure of the internal acoustic meatus. And that's how you see the tumor in the internal acoustic meatus. So that's a tumor in the internal acoustic meatus. That's a whole CP angle area. And I won't go too much into the details, but enough to know that you start way far laterally. The biggest advantages of the translabyrinthine approach is when you do a retrosigmoid approach, it's not always possible to retain serviceable hearing. So many a time when you go and drill tumors which are way far laterally in the internal acoustic meatus, you damage the posterior semicircular canal, or you damage one of the canal's ampullary ends, and that's where you don't really give always serviceable hearing to the patient in the retrosigmoid approach. The translabyrinthine approach can deal with tumors which are way far more laterally. It destroys the balance hearing so that the hearing on the normal side becomes much more clearer, and it is the earliest preservation of the facial nerve and identification. So there you go. That's the Bill's bar, and you can see the facial nerve protected behind the Bill's bar. You start your dissection way far laterally. Here, what you see is the sort of a horizontal crest over here, which divides the superior vestibular nerve from the inferior vestibular nerve, and you start your dissection and take the tumor down. So again, here, a quick video showing you the same thing. You can see in live surgery what we are doing. We need to identify the facial nerve. As you all know, most of these vestibular schwannomas arise from the inferior vestibular nerve. That's my hook going down there. We're taking the tumor down from the inferior vestibular nerve over here. Okay. And then on, we go about and just go a little further on this video. Having done this here, you can see I'll go on to the superior end, hook the superior ampullary nerve, take the superior ampullary nerve, which continues down as the superior vestibular nerve. And because I start so far laterally, the bone there behind the superior ampullary nerve is preserving the facial nerve. So as I take that, that's the bone I'm knocking on, you can see. And as I take this superior vestibular nerve down there, I'm going to be just seeing the facial nerve right behind it. That's there. That's facial nerve just coming to view over there. You can see very gentle dissection. Facial nerve is just about visible. That's the early identification of facial nerve. That helps to give the best results to the patient. So you see this, the horizontal crest is there, the tumor is being taken down lateral to medial, and you identify the facial nerve early and preserving the facial nerve by peeling the tumor off the facial nerve. Now, this has to be done extremely gently. There shouldn't be undue traction on the facial nerve. You should not work in a bloody field. Use liberal amount of irrigation so that your nerve is always in your field, and do not pull. You see, the nerve is never being pulled, and that's how you're supposed to do it. This is one of the most delicate of surgeries, and little amount of bad handling on your facial nerve, a little amount of stretch on your facial nerve could give rise to a grade 2 or a grade 3 result in the post-operative period. So there again, this is the medial end of the tumor. You can see the tumor over there. I'm just about dissecting off the dura over there, and I'll just go a little bit forward more on this. And here you see the dura being peeled off. I'm seeing the bottom part of the tumor over here. And what I'm doing is I'm opening up a little bit of the arachnoid, because this is not such a large tumor. So I can try to take advantage of the fact, and that's the facial nerve and the brainstem down there. Okay. So I've identified the facial nerve superiorly. I've identified the facial nerve at the brainstem. And what we do in all these cases is use a nerve monitor. You'll see me just using a nerve monitor after this step. Now use a nerve monitor, confirm that's the facial nerve over there, and then go about dissecting the tumor of the facial nerve. So that's the nerve monitor over there, making sure that the integrity of the nerve is beautiful. Even with a stimulus of as low as 0.3 milliamperes to 0.5 milliampere current, you'll get a good response, and you know that your facial nerve is very well preserved. And of course, then we go about taking off the tumor. So I won't go into the detail of this. The last part of the tumor removal, sorry, this video for the last part. I'll only show you the very last part of this tumor removal, and the facial nerve is really preserved completely exposed. So you see here, the tumor is just like a small ball over there. Just go forward. I'm dissecting the tumor off. You can see the CSF helping me wash off that blood from the plane, preserving the nerve everywhere, right from superiorly down. You've seen the nerve inferiorly, and I'm dissecting the facial nerve of the tumor completely. And then the tumor comes off as one big blob. So any blood vessels that are going into the tumor, you have to bipolarize and take it out. Make sure you're not bipolarizing too much. If the tumor is very large, you need to probably go about debulk the tumor and take it off. Okay? And you see over here, just the end. I'll be just done with the presentation in a couple of minutes to the organizers. So anyway, that's the tumor, and the whole tumor comes off like a beautiful, tumor. Now, if it's a large tumor, you need to debulk it and then take the capsule off the tumor, and then identify the facial nerve much more effectively and do a good case. Okay? So again, you see, these are just a few of the cases that I've done. I've got a fairly large series, and it's not always, these are all patients who are normal. It's not that we always get a normal face. There are cases where you would get a grade 2 result. That's okay, but as long as you have preserved your facial nerve intact, these grade 2s or even grade 1s that go to grade 3 generally revert back in 15 to 20 days back towards a normal grade. So we have got fantastic results with acoustic neuroma, but again, the size of the tumor is again a prognostic indicator. The tumors that are way above 4 centimeters, the chances of giving a normal face are far lesser, even with a normal integrity of the facial nerve preserved. So anatomically, you preserve the facial nerve, but in a tumor of larger than 4 centimeters, you have to give these patients a warning that yes, you may be left with a residual grade 2 or a grade 3, because size is a very big indicator, prognostic indicator for facial nerve function. So very good facial nerve functions, all tumor removals, and that's what. And with this, I think I would end my presentation. I'm already due with my time. So thank you very much for your kind attention, everyone.
Thank you, Dr. Jayashankar. It's a wonderful, very comprehensive and enlightening presentation. And I think for a change, we have had a surgical perspective to vestibular rehabilitation. Thank you, Doctor, once again for joining us today.
Thank you very much, everyone, and thanks, Dr. Neha.
I thank the attendees for the patience while we are getting ready for the next speaker. So I'm delighted to extend warm welcome to our esteemed director, Dr. Neha Shrivastava, to lead our next presentation. She holds a master's degree in MS ENT and has extensive expertise in neurootology and ENT. With her impressive background, Dr. Shrivastava is a true asset to our organization. As a young and accomplished member of the Bharani Society and the American Headache Society, Dr. Shrivastava has established herself as a leading figure in her field. Dr. Neha Shrivastava has authored numerous research papers and publications and has been an integral part of the workshops and conferences across the globe. She is practicing consultant neurotologist and ENT specialist at the RTKL Vertigo and ENT clinic in Mumbai, and also the co-owner of RTKL Diagnostic, Mumbai. Today, we are privileged to have Dr. Neha Shrivastava present on the topic of vestibular rehabilitation. Her insights and expertise in this field promise to be enlightening and informative, and we are grateful for the opportunity to learn from her. Over to you, Dr. Neha.
Yeah, my screen is visible now and I'm audible.
Yes.
Okay. So good evening, everyone, and thank you for joining in for the 8th webinar on vertigo and balance condition by American Institute of Balance India. I have been invited in the past by multiple organizations to speak about vestibular rehabilitation. Many companies also approached me to understand as to how posterography can be used as a technique with vestibular rehab, because all are well equipped in designing equipments, but when it comes to actually monitoring and exercising it on the patient, it becomes a challenge, because there are multiple things which are taken into account when you start a rehab in a patient. And also we have to understand the difference between unstabilized, stabilized, compensated and uncompensated patients. So when you go into rehab, there are multiple things which will discuss on today. So vestibular rehabilitation, basically the whole concept is based on vestibular compensation. We are lucky enough that nature has gifted us 5 organs. So even if the ear gets compromised, we have the other 4 to support, that is the brain, spine, foot and eyes. There is a complete utilization of the brain plasticity. The brain sees whatever it is shown and it adapts it very fast. So basically when there is a patient with vertigo, you have to change the ability, or maybe work on the cognition processes and the sensory inputs, along with strengthening of the muscles, so that you get the maximum utilization of the other 4 organs, and the patient starts compensating and stabilizing at the same time for vertigo. And there's a lot of dedication and motivation which has to be given to the patient, both from both the ends, even from the healthcare professionals and even by the treating patient, because you are their hope in getting out of this condition, which is very debilitating, and it can also affect their routine life. So how do you start it? Like, what are the basic evaluations you go into? So first is the posture screening. So when the patient comes to your OPD, you must see the gait of the patient as to how they walk in. The first thing that you must look for is whether the patient has any kyphosis. Kyphosis means there is an anterior posterior curvature where the concavity is in the forward directions. Apart from that, you will also look for scoliosis when there is a sideway curvature of the spine. Lordosis is often seen in patients, especially with the cervical spondylosis, that they are briefed about that they have cervical spondylosis. You'll see there's a muscle spasm along with cervical lordosis. So basically, lordosis is anterior posterior curvature along with the convexity in the convexity directions. And also you must look for the pes cavus. Pes cavus is the anterior posterior curvature of the feet, or you may also call it a flat foot. Second point is the sensory balance and the sensory evaluation in terms of the touch, temperature, the joint vibrations, and their proprioceptions. So these are very important point when you are checking your patients. Manual muscle test is just checking the power and the tonicity of the muscles, right from your major muscles coming from the shoulders, the upper limbs, and the lower limbs. Talking about the gait I'll be talking in detail in my next slides, wherein the modified Romberg's Fukuda and the CT-SIB scoring is very important. Cervical skinning is always important, because even if you are doing a maneuver to the patient, in the case of canalith repositioning maneuvers, you have to check the spine first. So the cervical spine, you need to check in all the 4 directions, that is the flexion, extension, rotation, and the lateral movements. Vertebral artery skinning test, also known as the VAST, is important if you are suspecting the patient with a vertebrobasilar insufficiency, wherein you will have to make the patient supine, lie down, extend the head, and flex it and laterally rotate it to the 30-degree. So suppose if you're checking the right side of the vertebral artery, the direction of the head will be towards the left side. And you must look for the 5 Ds and the 3 Ns. The 3 Ns are nausea, numbness, and nystagmus, and the 5 Ds are diplopia, dysarthria, dysphagia, dizziness, and the drop attacks. There is also there's something known as tuck test. Tuck test is timed up and go test. So basically, you make a patient sit on the chair, and place an object 3 feet away, and you ask the patient to get up, walk that distance, turn around, and come back. In a normal patient, it should be done within 14 seconds, 14 to 15 seconds of time. Anytime more than this is can be categorized under imbalance. So to name some of the vestibular evaluations that we often perform is head impulse test, test for nystagmus, which is always there in VNG. Then there is a visual acuity test, head shake nystagmus to look for vestibular hyperfunctioning, optokinetic test, which is a part of the central evaluations for vertigo, for positional test, and there is something known as, which I want to talk about, is the GANS SOP. So this is just a small brief as to if there's an example of an uncompensated unilateral vestibular dysfunction or a bilateral vestibular dysfunction, the patient will present with a history of a vestibular event along with vertigo, nausea, emesis. There can be an auditory symptom or there may not be any auditory symptom. The symptoms may be oxalophia, balance problem, a hallucination of the motion, or visual provocation. So how do we evaluate them? So when it comes to the major 2 reflexes that we evaluate, that is the vestibular ocular reflex. So that we do by gaze test, head impulse test, and the dynamic visual acuity test. For vestibular spinal reflex, which is an important part of the rehab also, and the gait evaluation is CTSIB, that is the clinical test of sensory interaction of the balance, along with Fukuda, high stepping gait, and the GANS SOP. And by that, we apply the technique of the vestibular rehabilitation, which includes adaptation, habituation, and substitution exercises. Permutation and combination of these exercises help us to get the patient out of the issues. So GANS SOP basically. So if you see the patient standing first is basically patient is standing straight with an eyes open. The second patient is in straight with eyes closed. Third is the patient standing in tandem with eyes open. Fourth is the patient standing in tandem with eyes closed. Fifth and sixth is the bit of challenge test when the patient is standing on a foam with eyes open. Sixth is the patient is again standing with eyes closed on a foam. And the fourth is the Fukuda test. So basically, when you how do we limit is 1 to 4, 5 to 6, and 7. So modified wrong-arm, there is no age norms. It can be done over age of 60. It is not so sensitive with respect to vestibular dysfunction, and it is always used as a baseline test. So basically, it's more for sensory ataxia. But some people also claim it that it is good for ruling out posterior circulation stroke. CT SIB, that is the clinical test for sensory interaction of balance. So basically, it's an vision denied test. So it can be we can add it by doing an head shake for the higher function, and it should be done in age less than 79 years of old, maybe 80 years to be considerate on. Fukuda is a high stepping test. Also, we can call it an Unterberger test, wherein you ask the patient to march around 90 and wait till march to 90 and wait for a minute or so and see whether the patient drifts for more than 30 degree on either side. It's a very sensitive test to define vestibulopathy, unilateral especially. So what are the vestibular rehabilitation techniques and what are the hybrid approach that we have? So we have the adaptation methods, we have the habituation exercises, we have substitution, and we have cognition uh, approaches for the patient. So coming to the adaptation exercises, the adaptation exercises are very simple exercises and they are basically done so that the gaze, there is more of gaze stabilization and there is reduction of the spontaneous nystagmus. One must be very cautious while doing this exercise because this can also lead to retinal slippage. You need to be very careful when you're guiding the patients for doing this exercises basically which are home based. So what you can do is, as you can see in the photo that there is a king and queen card which is given. So especially for saccades, you can ask the patient to hold the cards and see right, left, and maybe you can then ask them to see vertical. So this helps you to for the maintaining of the saccadic reflexes. The next is smooth pursuit, where it's just like reading a book. You can have a book and you can read from one point to the other, then come back. So it's more of a smooth pursuit exercise. Coming to focusing of the while turning head. So basically, you can have an object in your hand and you can turn your head right and left while keeping the focus on that particular object. So that is VOR1 exercise. The other exercise is the VOR2, where you carry the object in your hand and you move your head and the object simultaneously but in the opposite direction. So that also helps you in gaze stabilization. So adaptation are the main basics for any rehab to start off because when your eyes start perceiving things, your brain start adapting to that situation. The second is the habituation exercise. So habituation exercises are more about the horizontal head movement. So it can be also said as the head and neck exercises, wherein you can do the yaw, pitch, and roll movements. And also you can ask the patient to walk in a straight line and have the head turns while walking, so that there is the visual tracking of the patient improves over the period of time. So this is the second grade of the exercise, and you keep on increasing the frequencies as and when the exercises increases and the patient starts improving. Always remember, just like the cochlea has frequency turns, even the vestibular nerve has a turns. So it starts from 0.5 hertz to 6 hertz. So you cannot expect a patient of vertigo who has just got stabilized to go and dive and catch a ball, which is done by generally by our cricketers, because they also need to be trained and the balance will improve with the period of time. So coming to substitution exercises, this exercise are done basically on the physio balls or on the foams, There can be a static test and there can be a dynamic test also. Static test is you're like making the patient stand and then doing the test accordingly. And dynamic tests are done in tandem. So basically, when you're doing the substitution protocols, you need to have someone along with you to hold the patient, and you may also ask the relative to support them while they are doing the exercise on the foam at home. So these require specially trained healthcare professionals around them. So you can always have take help from the physio friends when you are going on through these exercises. So basically, the take home message is very simple, that the brain cannot fix what it cannot see. If there is no movement, there will be no improvement in the patient. Focus and concentration makes it better for the patient to improve with time. And cognitive treatment, that means that their ability to understand, integrate, perceive, and simultaneously reasoning is very important when you start giving them exercises. And it's a very important tool in vestibular rehabilitation therapy. My slide doesn't get over unless and until I speak about the canalith repositioning maneuvers. So basically, we all know that it's about benign paroxysmal positional vertigo, and there are many atypical variants of benign paroxysmal positional vertigo. But it depends. The choice of maneuvers very much depends upon the individual anatomy and the spinal abnormalities. For example, for treating a simple posterior canal, we have three different maneuvers. Like we have Epley's, we have Gans maneuver, and we have Simon. So that is based on the spinal mobility also of the patient as to how much flexion extension we are getting at the neck and the dorsolateral spine. So as we all know that there is Dixel Pike test and the supine roll test. So Dixel Pike, we generally do it for the posterior canal. We have the side lying test and the normal test that we do. And the supine roll test, we do it basically for the horizontal canals. Deep head hanging test, we do it for the anterior canals. So the treatment for benign paroxysmal positional is always a canalith repositioning maneuver. We have 14 types of BPPV and we have 12 different types of maneuvers. Symptomatic treatment can always be given with any kind of the vertigo medicines, especially when you want to give it, the choice becomes beta histine only along with PPIs. Vitamin D is very much important for the role of, for the recurrence also and for the avoidance of this attacks in the future. And monitor and follow is very important in the cases of positional vertigo. So take home message is every case is different. We don't have a standardized protocol in treating a patient, so it has to be tailor-made, customized, so that every patient has the defined treatment. I always say in my lectures that if there's more the symmetry between the two eyes or between both the parts of the body, there is higher chances of it being a peripheral vertigo. Central versus peripheral vertigo, you must always understand there are some red flags like 3Ds, diplopia, dysarthria, dysphagia. MRI brain is always, you can always take it into accountability if there is a mixed form of vertigo which is presenting in front of you clinically. And as always, I mentioned canalith repositioning maneuvers along with vestibular rehabilitation is an important stay of treatment in treatment of the vertigo and balance conditions. Medicines always have an adjuvant, and sometimes there can be main line of treatment, especially like how Dr. Nilotpal has mentioned in his lectures for migraine and Meniere's disease. But for rest of the cases, the vertigo medicine should not be used more than 3 to 5 days. So that's it from me, and thank you for attending the program. You can put up your questions in the chat box.
So thank you, Dr. Neha, for your insightful presentation. Our next speaker is Dr. Vidya Shenoy. Dr. Vidya Shenoy is a leading integrative therapist and dementia care specialist based in Mumbai. She is dedicated to improving the health and well-being of the aging population and spreading awareness about dementia. Dr. Shenoy is a member of several organizations, including the Alzheimer and Related Disorders Society of India, the Maharashtra State Mental Health Authority, and the Indian Federation of Neuro Rehabilitation. She is the founder of Smriti Vishwam, a dementia daycare center, and the Purple Citizens Brigade, a volunteer group for dementia. Dr. Shenoy has published several books and articles on aging, dementia, and integrative therapies, and is a regular speaker at conferences. With a passion for advocacy, she is committed to creating a dementia-friendly society and reducing risks through the integrative therapies. So over to you, Dr. Vidya Shenoy.
Thank you, Mr. Munshi. Thank you, Dr. Dutta, Dr. Jayashankar, and Dr. Neha, not only for presenting, but also for inviting me to this special webinar on vertigo and balance disorders. I'll share my screen now.
Yes, it's visible.
Yeah. So this has already been done by Mr. Munshi. And I like to acknowledge at the outset of the presentation, with humility and total surrender to the divine within, gratitude to people who have guided me through my pursuits in academics and professional learning, senior citizens, children, adults with special needs, those living with dementia, their families, caregivers. Special gratitude to my universe of memory, where we have people living with dementia and who have actually built up my resilience and my commitment that leads to a passion for any disability or disorder. I continue to learn, and that's how I grow. And today I'm having another part of my life improve upon. I present the fine art of balance. Debilitating condition, what is it? Vertigo is that which affects persons on domains of balance, physical health, activities of daily life, mental health, emotional, psychosocial, career, emotional abilities, intellectual and spiritual. It eventually affects quality of life and well-being. Vertigo and Balance, a therapeutic customized program of balance retraining, exercises that can help compensate for imbalance, adapt to less balance, and maintain physical activity. What are the other balances in life that we need to practice, whether it's work and life, family and work, our own existence, whether it is personally areas of recreation, our interpersonal relationships, health, our family and friend structure, society, workplace, it's all a talk of life balance. And vertigo, I think, does affect that balance. So here we have the brain and the heart, and we are all part of a life that needs this balance. And being sensitive human beings, I think we have to go more with the heart as well as our brain. It's beyond disease. Just by being there, what we do is we're actually helping somebody else and ourselves, thereby building relationships with people with sensitivity, love, compassion, empathy, and most importantly, patience, which most run out of. So it's a balance of the mind, body, and soul, the internal spirit, the physical and mental, emotional areas that we need to be very particular to. So what does it do here? We are applying the sense of balance to begin with the patient and the doctor. So there are times when, people have their own preoccupied thoughts. I think it's very important that both have a ear to listen to each other, the doctor especially with empathy and compassion. I know we run short of time in a very, very fast pace of life, but I think it's important because unless we hear, we are not going to connect. And if we don't connect, we are not going to be empathetic and actually reach out to people who need us. So what does it require? It requires soft skills that are often overlooked, and there's no training, especially in attitude. Sorry, the screen has gone off, right?
Yes, doctor.
Yeah, I'll just reconnect. We're having a dip in the internet at the moment. Sorry for that. So what is required is patience, empathy, communication skills that are very, very important. The wrong word could make a difference. And attitude. We have to help people build a confidence to work for a better quality of life. And a lot of times what we do is we hear and then the mouth talks soon after. So I think confidentiality between the doctor and the patient is extremely important, more so with a therapist or a counselor, because we have to follow the ethics that are required to be kept. We have to be professional, not be sentimental, but be sensitive, and for which we need good interpersonal skills. So here we come, what is the impact of this art of balance? We harness positivity in the other person, we increase their levels of confidence, increase and encourage independence, engage the patient's mind continuously, widen their social aspects and capacity to share and build bonds. So what is a support group? That I'm glad that AIB is, starting with that, because I think it's very, very important. So the support is essential for anyone and everyone, because it helps us cope with our challenges in life, whether they're physical or mental, and more so a support group would help share the experience with people who are on a similar journey. So it's very imperative to form a support group comprising of those who are not only facing common problems, but those who have the expertise to help out with a peer group session. And these groups, thanks to the internet, we can have it webinar based, online, and of course, the best is localized and in person. So finally, the peer or support group focuses on health, well-being, and encouraging people to live their lives to the fullest and living every moment as well as they can. So why is there a need for support or peer groups? It's to care and share, help one another, to travel comfortably with others on the same journey, same train, destination is the same.
Yeah, Dr. Vidya, I think there is some issue with
there is we are having a lot of major electrical. Yeah, so it's, educating about disease and symptoms, sharing what are the available resources, and also the ongoing research available, and actually creating meaningful connections to develop coping strategies. So sharing of experiences, offering mutual support, encouragement, and comfort to group members. So Praveen, give me this thing. I'm so sorry that, this thing had to happen.
No, it's all right. I know it's beyond your control.
I know that, but I apologize. It's an unstable. Let me try and get a dongle, so I won't, use the hotspot. So what is the impact of peer and support groups? It helps socialize. You can have a heart-to-heart talk. And most importantly, it, helps in communicating with one another. To sum it all, you be an angel. Uplift, extend your hand, get them aboard with you. Connect with them with care and concern. Tell yourself, I do care. So today's special food for thought is, I love these lines, Rachel Goodrick, when she said, we forget that sweetest joys are found in the simplest acts, hugs, laughter, quiet observation, basic movements, holding hands, pleasant music, shared stories, a listening ear, an unhurried visit, and selfless service. It is sad we forget a truth so elementary. thank you for lending me your ears and listening. And I hope I have been able to sensitize people who are present today, and we're always available to extend any support required for training, empowering with social soft skills. Thank you so much.
Thank you, Dr. Vidya, for that insightful presentation. I'm sorry about the interruptions
Yes.
in between, but otherwise,
Yes.
Excellent presentation.
Thank
And
you.
I think the point you made about the support group is very important, for uplifting the morale and providing motivation to the affected people, the affected group. Thank you very much once again.
Thank you.
We want to the next presentation. We now have Dr. Dinesh Singh, the final speaker of the day. He is highly accomplished physician and neurologist with an MD in internal medicine and a DM in neurology, both earned with top honors. He has established himself as a leader in his field. Recognized by the Economic Times as one of India's most promising and inspiring neurologists, Dr. Singh he has also received the Golden Aim Award for being the most preferred neurologist in Mumbai. He practices at Neuron Clinic in Borivali and Mira Road and is affiliated with renowned healthcare facilities such as Bhakti Vedanta Hospital and Karuna Hospital. With his expertise and dedication to patient care, Dr. Singh is sure to provide valuable insights and knowledge. I now invite Dr. Dinesh Singh to present on the topic of headache and migraine. Over to you, Doctor. Dr. Singh.
I think he'll be taking another 5 minutes, so maybe we can just play our MP4 format. Yeah. And also the link for the CME credit point.
That's right.
So Amol,
all those
can you
doctors
just do that for the minute? Yeah. Till the time he joins, he's with the patient right now. Another 2 minutes. Okay, just to brief you all on the credit points, there is a small link which is given of doc mode. So you will have to log in there, and once you log in, you can log in through your mobile numbers, also through your OTPs. There are some simple questions which have been put up, which is from the basic ENT and the Vertigo prospect. Answer those questions. Once you have finished answering those questions, you will be asked to pull up your registration number along with that, and the credit points will be credited onto your account in next maybe 45 days to 60 days. So please, there is a chat box. The link has been given there. It is https://bit.ly/doc mode. So you will be getting points from there. So don't forget to answer those questions, or else won't be getting the credit points for this program. So we are just waiting for Dr. Dinesh Singh to join in. So just let us wait for a minute or so because he's the patient right now. Till the time, I request you all to please put down your questions in the chat box so that we can take up in the panel discussion.
Dear Amol, can you put the link for the doc code so that those of the doctors who have not registered for the credit point, they can click on the link and register themselves.
So since the time, I think Dr. Dinesh Singh is joining, I and Dr. Nilotpal can answer some of the questions which have been posted. So there is one question about what we can do in intractable BPPV and a recurrent BPPV. So let me tell you that there is intractable BPPV till date. In my 5 to 6 years of practice, I have never seen such a case which has not got resolved with a perfect maneuver. And if at all there is a recurrent BPPV, then it is not a BPPV, it's a migraine. Because BPPV is clearly treated by canalith repositioning maneuvers. There cannot be anything else except for that. Or else the patient will fall into the category of maybe migraine. I find it very hard to digest when people say that in spite of doing 5 maneuvers, I have not yet corrected positional vertigo. To my belief, you have not treated that canal accurately, or you have not tested it properly. Secondly, there is one more question by Miss Shura. Yes, who has written that do we need to give any medication after canal repositioning maneuvers? See, again, as I come back to BPPV, it is all about maneuvers. But to my practice, I believe beta histine around 8 milligrams and thrice a day, and then taper it off works very well in cases of BPP, just to have the residual to stop the residual giddiness. And apart from that, you can always add on to vitamin D, and also check for the B12 level and the thyroids in these cases. So that's the answer for both the questions from my side. Dr. Jayashankar will not be available because he's gone to the surgery post the session. So with upbeat in VNG, you better go for an MRI of the brain to be sure that what's happening with the brain there, because there has to be something which is giving you that upbeat. I will also ask my friend and colleague Dr. Nilotpal to give some insight on that particular question which you have asked to Dr. Jayashankar.
Yeah, thank you, Neha. Regarding that question of upbeating nystagmus, basically, whenever we get an upbeat or downbeat or any gaze evoke, central vestibular nystagmus is basically due to irritability of the brainstem or the cerebellar regions, which are basically present in the posterior part of the brain. Now, what is this irritability? As we all know, there are a lot of neurotransmitters in the brain, like acetylcholine and norepinephrine, and then there is a GABA also. So GABA is basically a inhibitory neurotransmitter. Now, due to any of the effects, it can be hormonal, it can be genetic, or it can be any systemic disease, if there is a reduction in the amount of GABA in the brain, then there is a irritability that develops in the brainstem or cerebellar region. So basically, if we come across patients whose VNG we are finding a upbeat or downbeat nystagmus. Mostly these are due to irritability or a central change in the brain, which mostly can be due to migraine. So upbeat nystagmus in acute stage, very nicely treated with drugs like, I personally use drugs like clonazepam, liofen, baclofen, or 4-aminopyridine. So 4-aminopyridine is basically available in India in a form of delphin pyridine, which is available in India as in 4-aminopyridine is available in US, I think. In India, it's branded as delphin pyridine. So these are the medicines which you have to give in the initial part, in the acute stage of the upbeating nystagmus, and treat the cause. If the patient is having some symptoms or some history related to the migraine, or it can be due to any vestibular epilepsy, so then treat that cause along with the drugs which helps to increase the level of GABA in the brain, both for upbeat and downbeat nystagmus. Upbeat nystagmus is more common in migrainous patients. Downbeat nystagmus are basically due to any lesion in the cerebellum or the brainstem region. Hope I have made things clear. If someone needs some more explanation to it, can also mail me in my email, which is given in the question box. Thank you.
Nilotpal, if you can just answer this question, that is there a correlation between the iron dust and BPPV? Can BPPV present as an endemic disease?
No, basically what's happening is, in my part of the country, in the eastern region, whatever reference I get, whether it's a migraine or anyone having vertigo or anyone having a giddiness or noise-induced cochleovestibular disorders, they also are termed as BPPV. But first we have to sure that whether it's actually a BPPV or it's a vestibular disorder. Scientifically, I myself, I don't feel any correlation, scientific correlation between iron industry and BPPV. But there may be some cause which my Neha can give much more input in it. But from my point of view, I don't think so. But we have to rethink of the diagnosis. And if there is any traumatic injury or any job or any industrial activities where there is a chance of any trauma of the ears, then there is a post-traumatic chance of BPPV. But normally, iron industry, if you're having a lot of nerves, it doesn't scientifically correlates to any kind of BPPV, because BPPV is basically a mechanical disorder, as I already said.
Basically, we can also think about if there's an iron toxicity which is happening. So maybe we'll have to check out with the serum iron levels and we can have a study on this. Then only we can figure out as to is there any correlation. Maybe it can be in the research papers in the future. But as of now, we have not got much of the details. Neither me nor I don't think even Nilotpal will be having about the same. So there's one more question, Dr. Nilotpal, that why do some patients complain of heaviness of head after repositioning maneuvers even when the vertigo issue gets resolved?
This is basically, there is another article, if anyone is interested, that was published by me and Anirban sir, my guru again. So that is basically a post-residual dizziness following BPPV. It's basically due to some central positional changes which takes place because of autolytic overload, okay, and some changes in the brain. So in this part, I would much more go towards use of benzodiazepines like etizolam or clonazepam in helping this central vestibular compensation pathway, rather than using beta histine. It is my own clinical judgment which shows that beta histine, as it is a vestibular sedative, and as Neha in his wonderful presentation have shown about how it is important to maintain the vestibular compensation after a unilateral vestibulopathy to bring back to a postural stability. So it is much more advisable in the post-BPPV period to use drugs like benzodiazepine, that too only for a few days, to relieve that anxiety or that apprehension or a post-BPPV residual dizziness, that last quarter. Hardly these things go away within a period of self-limiting, and it will go away within a period of 2-3 weeks. In few patients, less than 30% to 40% of the patients, we need to give benzodiazepines for at least 4 to 6 weeks in this residual dizziness following the repositional maneuvers. Anything more, Neha, Dr. Neha, you like to add here?
No, I'm with you on this. We're on the same page. Yeah. So let me see this. Please share article for post. So Nilotpal, I think you will have to post an article of post-positional dizziness to Sachin. So please put down your mail ID, or Nilotpal, if you can just put your mail ID on the chat box.
I've already given it. I've already shared it.
You will get it. Yeah.
I've already shared it. Anyone, if they need it, just mail me in that mail. I'll share the both for the beta histine, role of beta histine in management of vertigo and post-BPPV syndrome.
Okay, so I think we are through with the questions as of now. We have just called a call from the team that they're connecting now. To which side should appeals be done if bilateral disc sulfide is positive? So whenever you get a bilateral disc sulfide positive, you need to understand the vector of the eye movement. So where is it going basically, and which side is more dominant? And also, when the bilateral disc sulfide positive means bilateral posterior canals are positive. Generally, we do consider Jacobineau's maneuver in this side, because when both the canals are affected on either side, we consider this to be a more of an anterior canal or a BPPV of the posterior canal, which may be downbeating. So you need to understand the movement. Is it going upbeat torsional, or it is upbeat up torsional and downbeat? So that you have to clarify in this question, just to be very specific as to where we are going. Nilotpal, you will have to add on to this, to which side this should at least be done if bilateral disc sulfide is positive. I would like to go with Jacobineau's in this case.
Myself, I have not till day in this many years of practice, I have not encountered any case of bilateral posterior canal BPPV. I have got encountered cases of lateral canal BPPV, which mimics sometimes. See, in some patients, which I would like to have Neha's opinion also later on, in some patients, in the typical Dick-Salpike maneuver, sometimes we don't get typical rotatory torsional nystagmus. But when we do a supine head roll position, we get this torsional nystagmus. So in my point of view, as in supine head roll, we are getting these things that can be confused with a posterior canal BPPV. But in my clinical practice, bilateral posterior canal BPPV, I have not encountered. Even if it's there, it may be rare. And if you have come across, but I have gone through a lot of lateral canal BPPV. And Yakubino, from my point of view, is the effective treatment maneuver for anterocanal BPPV. I don't have much idea about posterior canal if it's effective or not. I have not tried in any of the patients.
Yeah, so
This
even
is up to Neha.
yeah, it's very rare, whatever the question has been asked, but still we need to understand as to what is the directions of that particular nystagmus and which canal is dominant, because when we check it in our practice, we check all the three canals on either sides, and then we assure ourselves as to what maneuver we are going to take the accountability of everything, not only Dixel Pike. So that is how we proceed. So maybe if you could have given us more about the characteristic of the nystagmus, then we could have more specified
Yes, yes, we should
the
have more
answer and
localizing the
more
lesion.
specific, yeah, more localize the lesion where it is. But it is rare. It's very rare, you know. Okay.
Dr. Neha, I think if any other questions, we can finish it up because there is some emergency in there, so I may have to leave within next 10-15 minutes. So you are muted. Dr. Neha, please unmute yourself.
So I want to tell you that thank you so much since
Okay.
you joined in, and probably you can leave now. Okay. And
No, I will be there listening to Dr. Dinesh lectures. Will be a very important part of our neurotology day to practice, but I may not be able to communicate. Okay, it was wonderful session, and lot of questions are still awaited. This Vertigo, always when we give a webinar, there are huge lot of questions coming up. Everyone has got a gray area. What's it? And I would like to request the team to have all these regular discussions about this Vertigo and all topics every at least quarter, monthly or quarterly, whatever is visible. And is a very glad to be a part of this organization and got to today's meeting. And all the participants, thank you very much for our patient hearing. And you can also, my mail ID has been provided. You can, for any other issues or any links or any references, if anyone have it, I'm free to share that in the email ID. Thank you. Shubhratri. Good night, everyone.
Thank you, Dr. Datta.
Thank you.
It was a pleasure having you. Dr. Neha, any update from Dr. Dinesh Singh?
I just got a call from Arpit and he's told me that he'll be joining. So I'm just waiting for Arpit to respond. Okay, now there has been one more question. I'll answer it out. That post traffic accident, see, you always go for maneuver again. For BPPP, there's again and again, as I repeat, there's only one, only the canalis repositioning maneuvers work. But also you will have to look into labyrinthine concussions also, which can happen post trauma. So you need to differentiate them. You can probably, when the patient is stabilized, the stitches are off and the patient is fine, then you can think about doing a VNG. And these patients of road traffic accident are also quite acquainted to having the hematomas in the future. So there is always require your neurological evaluations have to be first done. And once the patient is stabilized, then you can go for the maneuvers of your choice.
There are a couple of people who have raised their hand. In case you have any questions, you can put it on the Q&A box.
So there are questions arising for the MMC point. Mr. Sunil, there is a request that you please go on the bit. There is a doc mode in the chat box which is given. You will have to log in. After logging in, you will have to create your account. When the account is created, put down your registration numbers, answer 5 questions on Vertigo, which has been put up by us. And once it is done, then you will be through for all this. The article for post-positional dizziness we will put up as has been told by Dr. Nilotpal. Okay, and treatment options for VPPV in pregnancy. She tried to manage. None of the vertigo medicines are quite safe when it comes to pregnancy. You can use meclizine. Meclizine is still relatively fine, but if it works and you have to just treat the patient symptomatically, or if you're in a position to do a maneuver, try doing a maneuver. If you don't want to do a maneuver, if it's the patient in the second or in the third trimester of pregnancy, then just try to treat the patient symptomatically by giving PPIs and ondansetrons or the anti-vomiting drugs. Don't try anything more than that. Amol, can you please put the link again because there has been request for this bit.ly link again and again from the doc mode platform. Please put it on the webinar chart.
Arpit, any update from Dr. Dinesh Singh? Ladies and gentlemen, I think Dr. Dinesh Singh is unable to join because he's in an emergency. So I think with that, we come to the end of today's session. And I think we'll have to close the session now. So it's with mixed emotions that we bring today's event to a close. We wish that we could have, continued. Just a moment. Give me a second. I think we'll just wait for 2 minutes, before we close, because there is some possibility that Dr. Singh may join. So kindly bear with us till such time. So dear attendees, as we have already explained, we have these two online international vestibular rehabilitation courses. The details are given on the screen, and you can subscribe for these courses. There's also a discount code which we have displayed, and the code is MAYWEB, MAYWEB, and this could give you a fillip and make you competent to basically treat the vestibular rehabilitation cases, that is patients with vertigo and dizziness. And for the ENT surgeons, neurologists, audiologists, etc., there's also the license program where you can start a center of specialty care, for which you need to acquire a license, which will give you exclusive rights to use the co-branding of AIB, plus you can operate the clinic. And this is coming to you in India at a very attractive rate. So I would request you to take this opportunity since we are running out of time. I think, ladies and gentlemen, we'll close the session here. So on behalf of the American Institute of Balance India, I wish to extend a heartfelt gratitude to each one of you for making this event such a memorable and enlightening experience. We would like to specially thank our esteemed speakers, Dr. Nilotpal Dutt, Dr. Narayan Jayashankar, Dr. Neha Shrivastava, and Dr. Vidya Shenoy. Unfortunately, Dr. Dinesh Singh could not join because of some emergency. So thank all these speakers for sharing their expertise and valuable insights on the diagnosis and treatment of vertigo and balance disorders, as well as discussing the role of medicines in this field. We even had a very refreshing session by Dr. Narayan Jayashankar, which was on surgery this time, which was a new addition. Your contributions have added immeasurably to the event, and we are honored to have had the opportunity to hear from all of you. And of course, we cannot forget our attendees. Your engagement, participation, and enthusiasm have been the cornerstone of this event and event's success. It is your support that has made this event a true testament to the power of knowledge and community. I wish to remind our wonderful audience that as a sign of gratitude, all attendees who wish to enroll for the International Vestibular Rehabilitation Certificate Course 1 and 2 will be entitled to a special discount Also, there is a special discount for neuro-otologists, ENT surgeons, and neurologists who wish to acquire an AIB license and become AIB Center of Specialty Care. You can contact us through the numbers displayed on the screen. We once again thank you all for making this event a success. With that, we come to the end of today's event. Thank you very much and Shubharatri. So thank you all. Good night.